Hello, everyone. Welcome back to Kin 506. Hopefully, you guys enjoyed your break. I know I did, and I know I needed it. Um, this week, we will be tackling pulmonary diseases. So, last time, I know it's been a while, we finished up the cardiovascular disease section. So, just for this week, we will be talking about chronic restrictive pulmonary disease and then asthma for the next set of videos, or singular video, I suppose. So here's a quick overview of chronic respiratory pulmonary disease. So it's a range of heterogeneous disorders with diverse pathological processes that contribute to low lung function and reduced thoracic compliance. So d despite the different ways that it can develop, the main things are reduced tidal volume, increased work of respiratory muscles, and less efficient ventilation. So there's two main categories that we can divide these restrictive disorders. So we have the extrapulmonary disorders, so things that come from basically like outside of the lung that still affect it. So you have neuromuscular disorders and stuff that affect the muscle, nerves, neuromuscular junction, or spinal cord disorders. So things like muscular dystrophy is an example, phrenic nerve paralysis, different types of syndromes like Eaton-Lambert syndrome for neuromuscular junction, and so on and so forth. The book covers that more in depth if you'd like. And then there's also the ones from trauma and mechanical disorders, so stuff that affect the chest wall or the pleural lining of the lungs. So stuff like fibrosis, metabolic syndrome, so on and so forth. So that would be category one. And then the second category would be intrinsic pulmonary disorders. So there's a lot more here, but um, yeah, things like interstitial inflammation and fibrosis, malignancy, pulmonary vascular disease, major lung resection, basically, yeah, removing a part of the lung, radiation exposure, infectious agents, and different types of inhaled particles. So the book has a lot more details about what each of these can be. Um, but regardless, whichever category that this restrictive disorder comes from, the common end result is a loss of alveolar capillary surface area and volume and impaired oxygen transfer across the pulmonary blood-gas barrier. Also, something that's commonly seen is reduced lung volume, with airflow rates reduced in proportion to the reduction of lung volume. Also, a quick note here. So, we've covered chronic obstructive pulmonary disease before, if you remember, COPD. Now, this is not that, it's restrictive pulmonary disease. So, the difference being obstructive is mainly, something's obstructing the airway, whereas restrictive, which is what we're talking about today, is directly impacting lung function and the tidal volume, um, and that gas exchange component of the lung. So it's not exactly obstructing it, it's restricting it. However, an obstructive component may coexist because maybe the person has developed the restrictive disorder following an obstructive one. So just note that quick little delineation. Now, a big thing about well, I'm gonna call it CRPD, so I don't have to keep saying that long word. But basically, there's a cascade here of physiological consequences. So if you guys remember earlier in the semester, we talked about this downward spiral of health and how one thing just leads to another. Well, for CRPD, there's something pretty similar going on. So bear with me here, it's a long slide, but um, they have the compliance of their lung reduced, and that leads to more negative airway pressure needed to inflate the lung. And that means that the respiratory muscles have to work harder in order to maintain whatever they're doing, whether it's exercise or regular activities of daily living. And then since their tidal volume is reduced, that means that ventilation now becomes less efficient, and that means that um, the work of breathing has to increase in order to maintain a given oxygen uptake by the lungs. So it's already difficult to breathe. Now you have to increase it even more because tidal volume is pretty low to begin with. On top of that, to make things worse, there's a larger fraction of total body metabolic energy that gets diverted to the respiratory muscles because again, it's difficult, right? That means that a smaller fraction is available for working limb muscles, and because there's a smaller availability, there's a greater buildup of lactic acid in those working muscles, and that drives more ventilation being needed in order to maintain, blood to those working muscles, which again means increased work of breathing. So you kind of see this cascade of just things keep getting worse and worse, right? Um, so yeah, but basically, if you do work with anyone with some form of CRPD, um, that may be something you see, and it often leads to deconditioning because of this cascade, because it's difficult to maintain their ventilation rate, given any activity that they're doing. Now, some common symptoms that people experience is shortness of breath upon exercise exertion, dry cough, pleuritic chest pain, and the pleura lines the lungs, just a reminder if you've forgotten. And then hyperventilation for people who are at a mild to moderate stage, and rapid shallow breaths in advanced stages. So those are some of the things to watch out for. Now, some long-term consequences that follow from this are respiratory failure, disordered breathing during sleep, right heart failure or cor pulmonale, and susceptibility to infections due to poor suction clearance, immunosuppression, or both. So it's pretty serious, of course. I mean, not like anything we talk about in this class is not serious, but that cascade is serious and it often leads to even more problems. So, what is the effect on exercise response? Well, we've talked about some of it, but um, just to add on to it, so there's a reduction in exercise tolerance and dyspnea in general, and that's mainly because of that cascade we talked about. So, there's inefficient ventilation associated because they have higher dead space, mechanoreceptor stimulation, and heightened central respiratory drive. So, those are some of the things that we see during exercise. And then impairments in exercise capacity are associated with declines in exertional arterial oxygen tension and oxyhemoglobin saturation. So, this is actually a really important point that probably has to be monitored given the person you work with. So, it may actually drop for that last part right there, the saturation. It actually may drop below 90% during exercise. And at that point, that's pretty dangerous. So, they either, you have to deal with it in one way or another. So, either reduce the intensity or give them supplemental oxygen, whatever it may be. Oh, sorry about that. Now, here's a table from the book that I think is pretty helpful. So we have talked about um, different types of medication in the past that affects the exercise response. So here's some other ones that we have not talked about overall, just because, we're not talking about cardiovascular diseases anymore, and we've been there for a long time in this course. So um, we have bronchodilators, so these may improve ventilatory response, ventilation perfusion matching, and exercise capacity. So that's actually a positive one, right? You have antihypertensive medication. So this is a beta blocker. We've heard of beta blockers before, and it may blunt heart rate response during exercise. So that's a clear hint to you that you may need to use RPE instead of basing intensity on heart rate. Systemic corticosteroid treatment may also increase blood pressure and induce muscle weakness. And then severe pulmonary arterial hypertension increases the risk of hypotension and arrhythmias upon exercise. So, yeah, know your patient, know who you're working with, and know how you're going to scale exercise for them. Now, what are the effects of exercise training? Well, as we've heard in many different cases of chronic diseases, exercise training always helps them. So here's a pretty long list of improvements. So we see improvements in submaximal exercise endurance, max oxygen uptake, ventilatory endurance, cardiovascular conditioning, peak exercise DL of carbon monoxide as peak cardiac output increases, oxygen extraction, skeletal muscle endurance, reducing lactic acidosis, and this is related to the like the peripheral muscles that are working so that respiratory rate doesn't have to increase because of lactic acid buildup. And then desensitizing their perception of dyspnea and their fear of exertion, and then improvements to their quality of life. So clearly, that's a lot of improvements right there. Um, Now, the main goal for exercise training for anyone with CRPD is one, to address the issues that are causing that restrictive disorder. So, if there are those underlying causes, it's addressing that and maintaining whatever lung function they still have. So, those two goals are the main things, and all of these kind of come along as a package deal when they start exercise training. So, what about exercise testing? Well, it is recommended to do an exercise test for this population because it can provide information on these three things. So, the level of disability due to their pulmonary dysfunction, detect coexistent factors that aggravate the disability, and then monitor the progression of impairment and response to therapy. Now, the book highly recommends a 6-minute walk test because it's pretty easy to do. I mean, it's a 6-minute walk test. It can happen in like most clinics, wherever the patient may be going or wherever you may be working with this patient, and it's easily reproducible. So, yeah, monitoring pulse rate and oxygen saturation is the key here. And they also say that you can provide supplemental oxygen if that saturation has decreased to a point where it's dangerous. So, that's their recommendation, but they do list a couple others if you would like to read up on it and get some more ideas. So, what about programming? What changes should happen for them? Well, they recommend the basic CDD4 recommendations for most people. However, they also say that depending on the level of severity or if it's very early CRPD, then the ACSM guidelines are actually good as well. So, not much has to change there. Now, the main goals are what's really different with this because, again, we're not dealing with cardiorespiratory. Um, Conditions anymore. We're talking about mainly lung function today, right? So the main goals are learning efficient breathing techniques and improving ergonomics during ADLs. Now, they recommend an initial period of like pretty intense training, as you could see here, 6 to 8 weeks, 20 to 30 minutes a day, 5 days a week. And that's to establish their baseline and see where they're at. Now they do note that if this is too difficult or if breathing does get too difficult during the session, they can divide this. So you can do 15 minutes, maybe in the morning, 15 in the evening, or 15 minutes here, take a small break, go back to it. So it doesn't have to be continuous, but just getting into that rhythm is the main key here. And then once they get to that point, the book does recommend that you can drop down to 3 days a week. So it doesn't have to stay at five if that's a little intense for the patient to fathom. Now, lastly, what are some special considerations for this group? So, worsening hypoxia should be monitored because it can contribute to chest pain and arrhythmias. Oxygen saturation should be over 90%. So, again, this is where monitoring it is very important because once it drops below 90, something needs to change. That's really dangerous. And then metered dose inhalers should be evaluated for proper technique and avoid extreme temperature or humidity. Now, hopefully that wouldn't be a problem if it's an indoor clinic, but if they want to exercise outside or, walk outside, depending on where they live, that's a consideration to take. Otherwise, everything else really stays the same. Um, yeah, not much else there for this population. So, hopefully that was helpful. Hopefully you guys learned something, and I will see you shortly for the video on asthma.